老师已经可以开始了。
Okay, thank you very much. So let's continue with the A section of the part 1 of non-stationary time series analysis with modern signal processing techniques. And so far, what we have introduced is synchrosqueezing that squeezes short-time Fourier transform or squeezes spectrogram. However, synchrosqueezing can actually be applied to squeeze other transforms, like continuous wavy transform, S transform, etc. But we will discuss it later if time permits. And also we will discuss quadratic time frequency analysis, like Wiener-Wheel distribution, or Cohen classes, or affine classes, and so on, if time permits. Okay, so target of today's session is the following. So far we have discussed short-time Fourier transform algorithm, synchrosqueezing algorithm, and some theoretical perspectives, some theoretical facts of those transforms. And now we want to take a look at some applications of how synchrosqueezing really can be applied for all the purposes we have introduced in the beginning. For example, how to visualize dynamics inside a signal, how to decompose the signal into proper components, and then extract dynamics and what does it mean. Then we try to learn something and predict something. This is a very first part of the applications. The first one will be application to peripheral venous pressure signal, PVP signal. And this is the reference of the result shown in this part. The focus of this part application will be visualized dynamics. So this is the slide I have shown you in the first session, which is about peripheral venous pressure signal. And again, it is ubiquitous in the hospital environment. And analyzing this kind of signal is actually very challenging. If you look at this signal, it is very difficult to really see what is included inside the signal. You may see, hey, sometimes there's an oscillation, sometimes, is this oscillation? And sometimes it's very big, large noise, and sometimes it's kind of, what the hell is it? It's a very challenging signal. And because of its challenging nature, actually, even nowadays, 2023, if you take a look at the signal processing part of this kind of signal, there may be not more than 10 papers. It's a very challenging one, although it has been widely applied in clinics, and there have been many clinical papers discussing how to use it, which we will not elaborate in this kind of course because it's maybe too clinical. Let's take a look at this signal and compare it with the photoplasmography signal, which we have discussed. If you pay attention, this is the first, this is a signal during 7 hours, actually 10 hours, or whatever, resuscitation. And this is the first hour of the signal. And you can see the PPG signal looks very nice, isn't it? It's very oscillatory, and sometimes you can see some low frequency component, and so on. But if you look at simultaneously the PVP signal, then you can see, the behavior is very, very different, although they are both trying to capture some hemodynamic information of our system. And you can see there are some kind of low frequency oscillation, isn't it? And this low frequency oscillation is related to respiration. Okay, but there are some kind of high frequency oscillation that is cardiac component, but it's hard to say. The second part of the signal after 2 hours, the second hour, you can see, hey, the PPG is still quite nice, easy to read, but what the hell is inside here, right? It's hard, it's difficult to say what's going on, and it's kind of fluctuating and so on. This is after the third hour. You can see PPG signal, good in the beginning, but then it became very, very chaotic, very, very noisy. What is included inside is hard to say. PVP signal is very kind of difficult, but then suddenly it becomes weirdly, well, smooth. So you can see the two signals. One is from venous pressure, one is from the blood volume. They are both monitoring your hemodynamic system, but they can have so much different behavior. So how to visualize it? How to analyze it? Again, the signal is roughly 7 hours long. If we take 7 hours long signal, then it is impossible for me to show you every minute or every hour signal so that we can go through everything. It's difficult. So what you can immediately see is, let's try spectrogram. And so you now apply spectrogram of the PVP signal, then what do you see? It is maybe not that easy to see what you get. You may say, hey, there is a bulb, right? And there may be some component, but very weak and hard to see. And then there is a very, very gigantic kind of noise. And then, what is it? Well, it's not easy to see, or to say what, too much. But if we apply synchrosqueezing transform, we can enhance the visualization. And that is the result. First, you see there is a curve. This curve is much obvious compared with short-time Fourier transform. And this is the cardiac component, which includes heart rate variability. And you can see this above, which you don't know what it is. But here you can see there's two components. There are two components. And these two components tell you that is about respiration. This is about respiration, okay? And here, right after this crazy bound stops, there is some kind of information which you cannot easily see. And then this part is totally blind, but you can see this is cardiac component. And the fact is, the patient was so ill, so that we have to install some ECMO, and so that after this time, the heart pump is controlled by machine, so the heart rate becomes very constant, and you can also see respiratory signal. So this is a very gross view of an ultra long signal, 7 hours long, and you can imagine if the signal right now is 7 days, you can apply the same tool and trying to study the overall behavior of the signal. And now we can simultaneously look at the photoplethysmography signal, which you can see a much stronger cardiac component, which is about 1.5 hertz. It's about your heartbeat. And you can see, okay, this is very clear. But the respiratory part becomes weaker. And this is the synchrosqueezing, which you can see the enhancement of each component. The enhancement of each component. Enhancement of each component. And from here, if you compare back with the PVP signal, you can clearly see that this is really the cardiac component, but not anything like noise or artifact. And this is really respiratory component. Okay, so if you pay attention to this part and this part, they are very, very close. And this part from PPG and this part in PVP is very clear. Okay, so far it's just visualization. Then we can obtain some practical information, like heart rate. So you have PPG signal, and as I told you, it's oscillatory. Each cycle represents one cardiac beat. So if you find all the peaks, you can determine the heart rate. So the red curve here is the heart rate determined from the PPG signal, which you can view it as the ground truth, because PPG has very strong oscillator cardiac component. But if you pay attention to PVP signal, it is kind of crazy. And even you apply some bandpass filter, you can see some oscillation, but oscillation is very irregular. But we can say, hey, there's still some information, so let's take the peaks. Okay, local maximum, okay? And then we use those local maximum points to estimate our heart rate. And the result is here. You can see that the heart rate estimated using the time domain landmarks of PVP signal is very noisy. It's fluctuating a lot. But if you apply synchrosqueezing transform to the PVP signal, this is what you get. You see a 9. And now you just extract this 9 by ridge extraction, and you get heart rate. The black one here is the heart rate from PVP signal via synchrosqueezing. So you see the heart rate right now coincides with the heart rate determined from polysomnography, photoplethysmography signal very well. So it tells you that actually PVP signal, although it looks very, very crazy, it does contain useful information like heart rate that can allow us to get more or companion information. And in particular, in some cases, maybe you lose the PPG signal or you lose the ECG signal, then you can use PVP signal as a surrogate. That is usually the case. Like you have several modalities, but sometimes some high quality modalities may fail. And in that case, we can use the low quality modality when it works to offer some low quality information, but still we have information. And now this is an example. I showed you in the very beginning. Over this segment of the signal, it is very difficult to see what's really going on. And I put a red dash here. And you also have the simultaneously recorded PPG signal, which I also put a red dash here. Now if you look at these two signals, can you see any specific difference before the red dash and after the red dash? It is very difficult, I can guarantee you. It's very difficult. But if you apply synchrosqueezing, then this is what you can get. Before the red dash, there is nothing. It's kind of, the pattern is crazy. But after the red dash, you can see a very beautiful pattern around 1.2 hertz. That's a 9 here. So what's going on? The patient, before that dash 9, developed some hypovolemia. And the physician see a kissing sign. So they know, okay, we need to give some fluid. So the physicians gave the patient some fluid. Okay, charge some fluid. And then they, right after this timing, they immediately see that the cardiac component returns, which means your fluid is more sufficient. So you can see some responses just by reading the time frequency representation. How to use this kind of feature, that is kind of ongoing project. It's not easy. Okay, but if you look at the PPG signal, then sorry, you cannot see too much. There's really no much difference before and after. So that tells you, well, by enhancing the visibility of the time frequency representation, actually you can see something in the time frequency domain. But so far, I only tell you how to visualize things. In the next example, I will show you how to use these visual features to design some features we have interest that we can use, well, to help patients. And this is another example during the cardioplegia, which is kind of just you try to help the patient, so you just redirect the circulation from the heart to some machine. Okay, and this is a joke in Taiwan who claims to be his expertise. Okay. I need to. Okay, so look at this. This is a signal, the PPG signal. And this PPG signal looks very chaotic. And for this chaotic PPG signal, you can still see a very clear curve line in the time frequency domain. And this line indicates the heart rate, which is very difficult to directly see from the signal itself. So this is what it means by robustness to noise. With this information, actually, we can do quite a lot. Okay, and this is actually a very disturbing signal. If you do the analysis, you see it. That is the signal that you observe from a patient before he or she passed away. Just a few minutes before the end of the life. You can see that in the signal, it's hard to say what's going on just by reading the time domain signal, but in the frequency domain, you can see something that is very unreasonable. We don't know what's going on. Physicians also don't know. Which, if you look at the time frequency domain, it seems that there's something yelling inside from the body. Yeah, very weird. Certainly, we don't know what's going on, and I would love to study more, but this kind of data is very difficult to obtain. Okay, this is the first part of the example. The second part will be, again, I want to show you some visualization of dynamics, and that will be the ECG-derived respiratory signal in patients with atrial fibrillation. Okay, so what is ECG-derived respiration, EDR signal? It is actually a signal you can obtain from your ECG signal, electrocardiogram. And the mechanism is very simple. Imagine that you are breathing and you inhale, then your chest will be filled with air. And the air will have higher impedance, so that the the electrical activity inside the heart will become weaker on the surface, so that the recorded ECG signal will have a smaller peak, smaller amplitude. But when you exhale, there is less air inside the chest, so the impedance decreases, so that the amplitude will increase. So because of this very simple mechanism, actually from the ECG electrocardiogram amplitude, you can recover to some extent the respiratory signal. And this is what it means by EDR, ECG-derived respiration. And there are many different algorithms to obtain EDR. And in part 2, when we discuss meaningful learning aided signal processing, we will come back to this issue and discuss how to use synchronization, how to apply bundle structures to enhance this kind of EDR signal. But today, I want to show you how does it work to study atrial fib in EDR signal in patients with atrial fib. Okay, so what is atrial fib or atrial fibrillation? It is a very simple mechanism. This is for normal heart, where you will have SA node, where the cardiac cell will self-pace itself, and the stimulation will be conducted to every node, atrial ventricular node, and then it will be buffered for a bit and go to the whole heart, so that you induce a ventricle contraction that complete one heartbeat. But in patients with atrial fib, there is not only SA node that is self-pacing. Inside the atrium, there are many crazy self-pacing nodes that are trying to kind of conduct something, so that the heart will beat at a very irregular way. So irregular so that you cannot predict what's going on. And this is how the ECG signal of a patient with atrial fib look like. You can see these two beats. They are very, very short, and sometimes very, very long. Sometimes very, very short, sometimes very, very long. It's very, very irregular. And if you use the same mechanism as I discussed before, just take the peak, right, and try to follow the magnitude, you will see that the magnitude oscillates in a super irregular way. It looks very, very irregular. So irregular that it is not easy to see if there exists any information inside the EDR signal. So this is an EDR signal recorded from a patient with atrial fib, and that is a simultaneously recorded respiratory signal using other modality. So you can see this one and that one, they have some similarities, but not too much. But if you look at patients with normal sinus rhythm, you can see that this is respiratory signal, and this is the EDR, and they can fit quite well. Okay, so, and this is the literature in case you have interest of study of this topic. And now let's take a look at the synchrosqueezing transform of a subject with normal sinus rhythm. So this is airflow, and this is its synchrosqueezing. You can see there is a curve, which is instantaneous respiratory rate. And this is EDR, and this synchrosqueezing. You can see these two. They follow very well. So you can visualize the dynamics, get the instantaneous respiratory rate. But this is a patient, this is a signal of a subject with atrial fib. You can see this is a respiratory signal, and you can see the dynamics due to synchrosqueezing. And this is the EDR signal, which looks just like noise or very, very irregular. But because of the robustness property of synchrosqueezing, you can see, hey, you can still get some dynamics. And it follows very well. It follows very well. And then starting from here, you are able to determine the instantaneous respiratory rate and use it to design some features, which I will elaborate in a bit. Good. So this is the second part, second application. Actually, I have several applications, and I realize that it has been 20 minutes. Okay, so I'll try to be fast, but let's see how far I can go. And now, this is about application to signal quality assessment of PVP signal. And it is about the third goal. We want to learn and predict something. And this is the literature, the paper of the related topic. So if you really work with real data, one thing you always been bothered is the signal quality, the data's quality. No matter if you work with time series, high dimensional signal, whatever you work with. Once you get data, the first thing is clean up, pre-processing. And that is always the most annoying part. And there are even some companies in America and in India who don't do anything, but just help you to clean up your data, to do data pre-processing. Okay, that is a big business. That's a big, gigantic business. Okay, and the signal quality is the key in this whole process. We need a way to quantify if a signal has sufficient quality for the mission you want to do. That's very obvious thing, right? Because when we record data, there's always noise, there's always artifact, there's always some imperfectness. But one very important notion here is, or concept here is, signal quality actually depends on the target, depends on your mission. I personally believe there is no universal quantity that can tell you everything. There is nothing like that. Okay? Actually, what we have is, depending on the mission, depending on quality we have interest, we design some signal qualities. And the low signal quality part could be denoised if the low signal quality is caused by noise, or it can be removed or imputed if it's caused by artifacts or missing data, etc. Third part will be the later topic that I have told you, and this one I will show you the second part. Look at these two examples. In these two examples, I can tell you the answer. Both are PVP signal. This signal has a good quality for cardiac component if you want to study hemodynamics. This signal also has a good quality if we have interest to study respiration-related information. But for this signal, it is bad in cardiac information if we want to study hemodynamics. But it is good if we want to study respiration. This is respiration. Okay, so it depends on what you want. And today, what I want to focus is the signal quality in the sense of cardiac information. Cardiac information. So if you look at this guy, it is hard to say, hey, if there is any cardiac component that follows, that oscillates following the simultaneously recorded electrocardiogram signal. It's difficult to say. This one as well, difficult to say. But this one, you can see it very clearly, very big oscillation, very nice, and it follows very well all of the ECG signal. This one as well. But for the signals in the middle, it is okay. We can say, oh, there's some oscillation, true, but it's weaker. So this is intermittent. And this one, well, in the beginning, looks okay, but what about the second part? Right? So that is called intermittent quality. And so the proposed signal quality index is based on the reconstruction or decomposition capability of synchrosqueezing. After you run synchrosqueezing, you get cardiac component, and from the cardiac component, you do decomposition. We will come back to details of decomposition later. Okay, but you can right now just imagine that the cardiac component, it oscillates down sinusoidally, so we just take all its multiples. We decompose all the harmonics and combine them together. But later on, I will tell you a better way to do the decomposition. After you do the decomposition, you get cardiac respiratory component, cardiac component, and the noise. And what we do is nothing but quantifying the strength relationship in between cardiac component and the noise, and ignoring the respiratory signal, because it is not the concern of this study. So what we do is, suppose the cardiac component oscillation has this kind of behavior. This is Fourier series, and we assume finite components to simplify the discussion. And usually it's finite components because it is on a very terminal and the venous part. Then we study just the signal to noise ratio. This is the strength of signal oscillation. This is the total energy of cardiac oscillation and the noise. And this is called the signal quality index, which you can view it as 1/1 plus 1 as the NR. Signal to noise ratio is the ratio of the signal strength divided by noise strength. Okay, so this design is to allow the index to be located in between 0 and 1. Okay, and this is another example without cardiac component. So you can see this is a respiratory component, quite nice, but cardiac component, noise, so the signal quality index is very low, 0.25. And that is a synchrosqueezing transfer. And this is a distribution of various different signal quality indices. This is what we proposed, and you can see there's a very obvious difference of two distributions. The ROC curve is also very nice. And here what we do is we take intermittent and good quality as high quality, and the 0 is low quality, and we run ROC curve to divide them. And there is entropy, you can consider total power or mean venous pressure, which are common indices used to determine the signal quality. And you can see their performance is not very good, but they do contain some complementary information, so we can combine all of them to train an SVM model. And this is the final result, which we consider F1 0.89, quite nice. So, an open question before we close this session is the following question: what do you really mean by good? What do you really mean by good? In the previous signal, in the previous session or example, what I showed you was about cardiac component. And I assume that the subject does not have arrhythmia. Suppose the subject has arrhythmia, then how to do the quantification? We need a separate different model to consider it. And that model will depend on manifold structure. And that is the part 2 of the topic. For example, you can imagine, right now I am talking, right? I am talking. So what I can do is I can record my respiratory signal. I can put some nasal cannula in my nasal. And nasal cannula, if I don't move, I record very well, but I am just talking. Then what do you imagine? Will my respiratory signal be oscillatory like what you are breathing right now? No, right? But this signal should be considered of high quality, but not low quality, even if it looks like noise. Okay, so it really depends on what quantity you want to handle. Then you can say what it means by high quality or low quality. And again, as I mentioned, I will come back to this topic in part 2. And let's continue in the next session. That's for it.